If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome, I'm Fernando, a GP in the UK. In today's episode, we'll go through recommendations on the diagnosis and monitoring of type 2 diabetes using HbA1c, focusing on what is relevant in primary care only. This information includes guidance by NICE contained in the NICE guideline on type 2 diabetes. The link to it is in the episode description. Right, let's jump into it. Let's start with the diabetic diagnostic thresholds. They could be an HbA of 48 or 6.5% or more, or a fasting plasma glucose level of 7 millimole per liter or more, or a random plasma glucose level of 11.1 millimole per liter or more in the presence of symptoms or signs of diabetes. Why have these thresholds been chosen? These thresholds are based on the evidence of glucose levels at which the risk of diabetes-related complications, particularly retinopathy, increases significantly. They have been agreed in order to strike a balance between diagnostic accuracy and early intervention, helping to catch diabetes at a point where treatment can prevent progression and complications. And let's also remember that if the person has symptoms of diabetes, a single abnormal HbA1c or fasting plasma glucose can be used, although repeat testing is always advisable to confirm the diagnosis. However, if the person is asymptomatic, we should not diagnose diabetes on the basis of a single abnormal HbA1c or plasma glucose result. Instead, we should arrange repeat testing, preferably with the same test, to confirm the diagnosis. If the repeat test result is normal, we will monitor the person for the development of diabetes, and the frequency of this monitoring will depend on our clinical judgment. This guidance not to diagnose diabetes in an asymptomatic person based on a single abnormal result is based on principles of biological variability and the importance of avoiding misdiagnosis. This is because glucose levels and HbA1c can fluctuate due to a variety of reasons, and a single abnormal result may not reflect the person's usual glycemic status. Repeating the test helps rule out false positives due to possible transient factors or a lab artifact or error. Can we use HbA1c and plasma glucose interchangeably to diagnose type 2 diabetes? Well, in general, yes, but there are times when HbA1c should not be used to diagnose diabetes. This is the case for children and young people under the age of 18, pregnant women or women within 2 months postpartum, people with symptoms of diabetes for less than 2 months, people at high diabetes risk who are acutely ill, people taking medication that may cause hyperglycemia, for example, long-term glucocorticoids, people with acute pancreatic damage, including pancreatic surgery, and people with end-stage renal disease. Additionally, HbA1c should be interpreted with caution in people with abnormal red blood cell turnover or abnormal hemoglobin type. For example, abnormal hemoglobin such as hemoglobinopathy, including sickle cell trait, severe anemia of any cause, altered red cell lifespan, for example in post-splenectomy, and a recent blood transfusion. Why do we need caution in these situations? Well, HbA1c reflects the percentage of hemoglobin that has glucose attached to it, essentially giving us an average of blood glucose levels over the past 2 to 3 months, which is the typical lifespan of a red blood cell. However, anything that alters red blood cell turnover or hemoglobin structure can affect the accuracy of this measurement. For example, in conditions like hemoglobinopathies, like sickle cell trait or thalassemia, the structure of hemoglobin is different, which can interfere with how HbA1c is measured or how glycation occurs. In severe anemia or increased red cell turnover, red blood cells are cleared from the circulation more quickly, so there's less time for glucose to attach, leading to falsely low HbA1c levels. Conversely, if red cells live longer than normal, such as after splenectomy, HbA1c may be falsely high because glucose has more time to accumulate. And finally, after a recent blood transfusion, the donor's red blood cells, often with a different glycemic history, can distort the results. So in these cases, HbA1c may not accurately reflect the patient's glycemic control, and alternative measures like a fasting glucose or an oral glucose tolerance test may be more reliable. What about diabetic monitoring? NICE recommends that we should measure HbA1c levels in adults with type 2 diabetes every 3 to 6 months until HbA1c is stable on unchanging therapy, or every 6 months once the HbA1c and diabetic therapy are stable. If HbA1c monitoring is invalid because of disturbed erythrocyte turnover or abnormal hemoglobin type, we will need to estimate trends in blood glucose control using one of the following: quality controlled plasma glucose profiles, total glycated hemoglobin estimation if there are abnormal hemoglobins, or fructosamine. What do these alternative forms of monitoring involve? Well, quality-controlled plasma glucose profiles involve measuring fasting and postprandial glucose at regular intervals, giving a day-to-day picture of control, although they don't reflect long-term trends as well as HbA1c. Total glycated hemoglobin measures all forms of glycated hemoglobin, not just HbA1c, and may be more accurate when variant hemoglobins interfere with standard HbA1c assays. And finally, fructosamine reflects glycation of serum proteins, mainly albumin, rather than hemoglobin, giving an average of blood glucose over the past 2 to 3 weeks. As we have said, it's useful in cases where red blood cell lifespan is abnormal, but also in pregnancy or when rapid changes in glucose control are occurring. Each of these methods has limitations, but they can give a more reliable picture than HbA1c when red cell-related interference is present. What about HbA1c targets? NICE advises that we should discuss and agree an individual HbA1c target with patients, encouraging them to reach and maintain it, unless any resulting adverse effects, including hypoglycemia, or their efforts to achieve their target impair their quality of life. However, from a general perspective, for those managed either by lifestyle and diet alone or combined with a single drug not associated with hypoglycemia, we should aim for an HbA1c target of 48 or 6.5%. For those on a drug associated with hypoglycemia, we will aim for an HbA1c target of 53 or 7%. In adults, if HbA1c levels are not adequately controlled by a single drug and rise to 58 or 7.5% or higher, we will review and reinforce the current treatment and then proceed to intensifying drug treatment, generally by adding a second drug. These thresholds are heavily influenced by the results of clinical trials such as the UK PDS or United Kingdom prospective diabetes studies, which is still one of the most influential long-term randomized controlled trials on glycemic control in type 2 diabetes. It showed that intensive blood glucose control targeting HbA1c around 53 or 7% significantly reduced microvascular complications like retinopathy, nephropathy, and neuropathy, and additionally, long-term benefits for macrovascular outcomes emerged in extended follow-up, giving rise to the so-called legacy effect. What is exactly the legacy effect? Well, it describes the fact that participants in the UK PDS randomized control trial were followed for 10 years after the trial ended. Although the differences in HbA1c between intensive and conventional groups disappeared within a year, the intensive group still had significantly lower rates of both micro and macrovascular complications as well as all-cause mortality. In a way, this showed that early good control leaves a metabolic imprint that protects patients long-term, even if later control becomes less strict. However, although tight control can be beneficial, we will consider relaxing the target HbA1c on a case-by-case, with particular consideration for people who are older or frailer if They are unlikely to achieve longer-term risk reduction benefits, for example, people with a reduced life expectancy. If tight blood glucose control would put them at high risk if they develop hypoglycemia. For example, if they are at risk of falling, they have impaired hypoglycemia awareness, or they drive or operate machinery as part of their job. Or if intensive management would not be appropriate, for example, if they have significant comorbidities. This is because there is strong evidence that in older or frail adults, sometimes the risk of hypoglycemia may outweigh the benefits of strict control. In particular, the ACCORD trial found that intensive glucose lowering with a target HbA1c of less than 6% increased all-cause mortality in people with type 2 diabetes at high cardiovascular risk. In fact, the trial had to be stopped early due to this excess mortality. Our take-home message is that tight control is not always safe, especially in older comorbid populations. On the other hand, if the HbA1c level is lower than the target and they're not experiencing hyperglycemia, we will encourage them to maintain it, being aware that there are other possible reasons for a low HbA1c level, for example, deteriorating renal function or sudden weight loss. So that is it, a review of the diagnosis and monitoring of type 2 diabetes. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening and goodbye.